Good everyone, and welcome to today's webcast, Psoriasis and Skin of Color. My name is Corinne Pettit, and I'll be your moderator for tonight's presentation. Before we get started, I wanted to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right-hand corner. You've joined the presentation listening using your computer speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane and then dial in. The dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenter by typing them into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell you about who we are here at the National Psoriasis Foundation and what our mission is and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice of millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. Nationwide, our volunteers are visiting their local elected officials, asking Congress to support legislation to increase access to treatment, and funding for psoriasis and psoriatic arthritis research. They also are raising money and awareness through our Team NPS events and educating the public about psoriatic disease through our community ambassadors and volunteer program. If you'd like more information about these opportunities, you can log on to our website after today's program at www.psoriasis.org. Next, on behalf of the National Psoriasis Foundation, we want to extend our thanks to Lilly for their sponsorship of today's educational webcast and making this presentation possible. Now I would like to introduce our guest speaker, Dr. Paul Wallace. Dr. Wallace has overseen the operation of Wallace of Beverly Hills since 1993. A native of Los Angeles, he's always believed in innovative approaches to help patients look and feel their best. He graduated with honors from UC Berkeley and then went on to Harvard Medical and the University of Oklahoma and University of Missouri graduate schools. His residency training in dermatology and fellowship in reconstructive and plastic surgery was done at the Charles Drew Martin Luther King Jr. Past decade, he has been an attending physician at Cedars-Sinai Medical Centers and is the clinical director at San Mateo Medical Center. Dr. Wallace is a member of the U.S. Army Reserve and specializes in military trauma and wound ballistics. Dr. Wallace has lectured to elected officials, athletic directors, physicians, trainers, coaches, healthcare professionals throughout North and South America, mainland China, Macau, Hong Kong, Thailand, Indonesia, Europe, East and West Africa. Most recently, he spoke at a National Psoriasis Foundation organized congressional briefing on psoriasis and skin of color. So with that, I will give the reins over to Dr. Wallace.
Thank you very much. I certainly appreciate it. I'm always excited anytime to talk about psoriasis, pretty much in any form. And so thank you for giving the evening time to me and the National Psoriasis Foundation. I'm really indebted to them for allowing me such a pleasure thing to do, but also being able to speak to voices across the country and around the world about the importance of psoriasis. It's far more than a skin disease. It's actually, as you all should know, it is an inflammatory disease that covers the whole body. And with my patients, we not only try to treat the disease, what we try to do is to change some thoughts and some lifestyles to better health, because when it's all said and done, I'm interested in your total health, the quality of your life, and the longevity that you will have with regards to your life, and psoriasis should not play a great part of it, although it should gear you along the way in terms of some of the choices that you have to make. The great news, of course, in the last at least 20, 25 years, we have tremendously fabulous medications that are out. Every person is a little bit different. I think the website of the NPF is fantastic in being able to give you some baseline information, and today's presentation is going to let me talk a little bit about that. Obviously, out in front of you, we'll talk about what's going on with psoriasis, where the thoughts are, the epidemiology of it. There's different types, there's different severities. I'll even tell you where I have some problems where the National Psoriasis Foundation and I sort of bump heads just a little bit. We'll talk about quality of life, which I think is the most important thing that people need to understand about folks with psoriasis, and then we'll talk about some treatments along the way. Well, there's a lot of information with regards to psoriasis, not nearly what we need to know, and I'm going to say it more than once. We don't have a cure. We have a good understanding. We've got some great treatment options, but we don't have the cure for that. But right now, we're getting so close to the standard being at least about 75 to 100% clear of the cutaneous manifestation, and to put people back to work with regards to some of the arthritic component that's there. You see that in the United States that they have African American and Hispanics, and internationally there's that. Now, I had the good pleasure of starting back in 1995 of being a visiting professor in Guangzhou University in China, and it was extremely interesting watching how they had hallways of patients that had psoriasis with Chinese medicine on the right side, Western medicine on the left side, and I am one who believes that if we can take the best of medicine, whether it's from the East or from the West, you utilize all of those. And most of my patients are certainly doing some things that are not necessarily traditional or just westernized medicine. Of course, there may be those who are taking injections or using topical creams or taking some pills by mouth, but they also very much are with regards to their hydration, which is so extremely important. I find that most of the patients are dehydrated, which certainly increases the overall inflammation that they have, and getting that inflammation down is so important, doing it globally, doing it throughout, not just on the skin. So there's a lack of genetic research along, and there's several different studies, and it's so difficult with regards to the information on psoriasis. And one of the reasons why, as I said, in different parts of the country, again, I'll use China as an example. At certain parts of China, up to 10% of the population have psoriasis, and other parts of the population maybe only 4 or 5%. Probably know that here in the United States, we're talking about 3% of the population having psoriasis. And we're not quite sure what all the variables are. There's certainly a genetic component. There is an environmental component. And there's a behavioral component that's associated with it all. Now, there's different types of psoriasis. The most prevalent, the most what we see is the plaque psoriasis, but there are of a wide variety. Now, one of the problems with regards to skin of color is even in the description out of most of the things that you learn in medical school and as residents doing the dermatology, and even the tests that come, you may describe something as being salmon colored. Well, I'm a dark-skinned African American, and you won't see salmon colored on me. You don't see the skin blushing, but you could see what you see on the right there, a silvery patch that's there, and that's often misdiagnosed. The information that the National Psoriasis Foundation has that it may take up to 6 dermatologists before people of color actually get the correct diagnosis and treatment for such. The issue with regards to the hyperpigmentation or depigmentation is a bit different with regards to skin of color, on how the melanocytes, on how the color-producing cells react. So it makes it difficult if you don't know what to look for and don't ask the question first. Now in this, one of the things that they talk about with regards to severity has to do with the body surface area. And that's where I'm a little bit at odds with certainly the insurance companies, and many of the other institutions have to buy into that. But I'm here in Beverly Hills, and I know that folks are hating that. It's about 73 degrees right now, and I've got all of the folks for Hollywood. We're talking about the Oscars are coming, major shows that happen. You're talking about your TV and film industry. You'll be surprised at how many of those individuals actually have plaque psoriasis. Now, behind the scenes, you've got hairstylists, you've got makeup artists, and oftentimes they may have it only on their palms and their soles. I've had patients who come who have bloody hands, bloody feet, they're in pain all day, and we'd like to sometimes think, well, you know something, you only have 1 to 2% of your body surface area, so that must mean that you're mild, and that's where my disagreement goes. Now, in other folks, it's just quite mild on their hands, and it's not there, but they may have 20, 30, 40, 50, 60, 70% of their body covered, and we certainly understand that that can be a severe case along the way. But I never discount what the severity is on any patient. In fact, I usually ask the patient, how severe is this with you? Do you consider it to be mild, moderate, or severe, and how does it affect your life? The slide that we're looking at right here gives a good example of what's going on in terms of, again, body surface area, and this, unfortunately, is often the lead parameter that's looked at in terms of what medication will be made available. In different cultures, the psoriasis is taken differently. And there are some cultures that have a big pushback. They are thinking that, oh, it's infectious, that there's no way. And I have to admit, if you take a look at some of the psoriasis, and if you're not familiar with it, if you don't know someone with it, if you're not in the healthcare industry, it very much looks as though that it's contagious. So part of what the National Psoriasis Foundation does is gets the word out and a better understanding about psoriasis. One of the things that I've always noticed is that, unfortunately, psoriasis doesn't get much sympathy from legislators or from the general public. You don't see any major telethons going on with that, and part of it is because it's not understood. Part of it's because they think that it's only a skin. Oh, that's just dry skin. You can do something with it, put a little lotion on it. If they only knew the other things that were associated with it, if they knew that there was a higher increase with regards to cardiovascular or heart attacks and strokes, if they knew what the weight of having that disease was, and that everyone's looking at you, and the fact that if you could just be invisible for a period of time, if you're a patient who has this on their hands, their face, or their scalp, they don't understand that, and the National Psoriasis Foundation does a very good job of getting that word out. Okay, so there's a lot of mimickers with regards to what goes on. People don't understand what is happening. Is this a fungus that's there? Is this a temporary situation because you see a discoloration that's there? I would admit that probably about 75% of the patients that I see who come of color have been misdiagnosed in thinking that it's anything from the lupus that you see there to, and most commonly called, a fungus that's associated with it. Now, there's a number of other barriers that happen. Some of them are the patients sort of bring it to themselves, in that They wait until the level of severity is so great that many dermatologists who aren't used to seeing people of color are confused, but they're also scared that they don't want to do a biopsy because they could end up with a keloid, or the scar could be very unsightly, so they could go for weeks to months with the wrong diagnosis, using the wrong medications. For example, I said the fungus, so they're given multiple different fungal creams and not knowing which one to use along the way. So undiagnosed patients were more likely to be, again, non-Caucasian, oftentimes not being able to communicate exactly when things started, what sort of stuff has gone on, don't often journal about what goes on, and interesting enough, unmarried. Now, this slide, talking about the quality of life, I think is the most important. I have to also say that for my patients who have had moderate to severe psoriasis, when I have my one-on-one talk and we're talking about the disease, from the toughest of guys to the toughest of females around, talking about the burden of psoriasis can bring a tear or an outright cry. That is what the general public doesn't understand. Talking about the feelings that are there. Oh yes, we know the issues and problems with regards to sleeping and walking and sitting and feeling uncomfortable. You know, I explain it like this. It's almost like going to bed at times, taking a bunch of potato chips, crunching them up and putting them on your sheet. You know how uncomfortable that would be. But guess how uncomfortable that is for whoever's lucky enough to have a significant other, to be able to live with that night after night, and certainly prior to the last decade or so, knowing that there wasn't going to be any change. The problems with regards to daily activities and with the arthritic component associated with it. Also, for those of you on the East Coast that have the snow, my grandfather's back in Boston was telling me about how it was -1 degrees, although he doesn't have psoriasis or psoriatic arthritis, how difficult it's got to be to have this uncomfortable shedding of skin, tender skin, hypersensitivity, the arthritic component there. This is why, for me, the quality of life index is so important, and that's what allows me to make a determination on whether it's mild, moderate, or severe in my patients. Now, it's always interesting with regards to the different surveys that go out, but there are cultural differences in terms of complaining about a particular problem, how long it takes before you go and seek medical help, and the fact of how much does it impact you. As I mentioned, different communities often look at disease differently. Certainly those that have a better understanding can sometimes even embrace, but they certainly don't fear. There's others that think that this can't be anything. Now remember, the two diseases that are most likely by the general public confused with psoriasis are, one, there are those who think that it must be leprosy, and two, there are those who think that it must be HIV. Obviously, if you knew anything about either of those diseases, you would know that it's not psoriasis. But I can't tell you how many times there's been an individual who's come into my office and said that this is exactly what people thought, which is why they were scared that they were contagious. And the response of the general public can be brutal. From physically beating down a patient of mine who tried to pick up a ball that a child had dropped, to one of the cases of where they needed to sue one of the national chains of exercising, 24-hour fitness was it. They won the case, but what they asked for was not a monetary settlement. What they wanted is to have the opportunity to go into the gym and work out. And what happened? They allowed them to do that, but they had somebody follow them with a bottle of bleach and wash down everything again, not educating themselves, but fearing that the other people who were there would not touch their instruments and they would lose business. They went around for show and used bleach to clean up after them. Well, adding to the impacted areas, and of course you've got the self-consciousness and the embarrassment in that, I found more than anything the depression that goes with this. It goes often undiagnosed, and if it's not asked, it often isn't volunteered. If you have two sides, on my left side I have depression, on my right side I have psoriasis. Let's go down the list. Oftentimes sedentary lifestyle, yes, for both. Alcohol abuse, yes, for both. Drug abuse, yes, for both. Spousal abuse, yes, for both. Obesity, yes, for both. Increased cardiovascular issues, yes, for both. Strokes, for both. So as you go down the line right now, the only difference, if I said, and what about their skin, extra plaques and extra growth? Oh, well, then that's psoriasis. But up until that point, every point could be both. With regards to my patients, we certainly talk about that. I think that the blogs and groups and even having talks with regards to psychologists are extremely important. And guess what? They all seem to do better with regards to the effect of their medications along the way. Understanding this, having family members, colleagues, co-workers arrest, understanding psoriasis certainly helps along the way. Okay, overview, it's chronic. It is not cured. I've got a number of patients who are walking around that don't have a pinhead worth of plaque on them anymore, but it is not gone. There's some great news about that and not so good news. What's the great news is that we were able to find something for them that worked fabulously. Not so good is that many of them think that at that point in time that I can stop using my medication as it was prescribed. I can start treating it as I want to, when I want to, as much as I want to, and there's some problems that are associated there. No single treatment works for everyone. That's an absolute. However, I'm going to go back to some of the things that I mentioned earlier. I think sometimes a change in lifestyle of understanding that doing things that will help to bring down inflammation over the whole body is very important. And number one, and perhaps the easiest, is being well hydrated. My patients, I ask for them to be about 50% of their body surface area, of their body weight in ounces. So I'm about 200 pounds. I try to drink. I get close to about 100. And for me, that's somewhere about, 6 bottles of the little 16-ounce bottles over the course of the whole day. Sometimes I tell patients, you know something, it's a lot easier if you have some of those 8-ounce water bottles. You can drink one of those, throw them away, and keep stepping. Other people can bring in a whole gallon bottle, and they say that I'll drink that down a little bit at a time. There's nothing wrong with adding in some fruit, adding in some vegetables, although I shouldn't say it, even a drop or two of honey and give it a little flavor there. Don't make water a punishment. It's a treat to yourself, and you'll feel so much better. And although that alone may not have a significant effect with regards to your plaques, it's going to have a tremendous difference with regards to your overall quality of health, how you feel, and I can pretty much guarantee you how you look. It's not unusual to go on one treatment and then change over to another. There's more than one way home, right? From wherever you work or go to school or that, you have more than one way to get you there. Sometimes it's the more direct way. Sometimes you got to go around a few corners. Sometimes you have to avoid some traffic, especially here in Los Angeles. When we talk about the 405, you may need to find a different way to get you where you need to go. So switching treatments, having multiple treatments at times, you're just regular. It's not that you are any more difficult. We just need to find out what's going to be best for you. We've got all kinds of issues and problems with insurance companies and the rest of that. We find someone who's going to fight for you with regards to that and making as many options available. And there's some docs who aren't treating psoriasis, so you need to find out if that's what their interest is. Phototherapy can be very important, especially in the places, as I said, the Northeast, the Northwest, those places that don't have a lot of sunlight. Here in Southern California, most people have enough of the sun exposure to be outside, to go to the beach, to take walks and that. But those that don't have that, phototherapy for many can work exceedingly well, especially with itching. There are some problems with regards to people of color, especially with regards to post-inflammatory hyperpigmentation, which just means getting darker in those areas. And it is very, very easy to burn. You may have one area that can tolerate it, but another area might be very difficult. So that has to be watched. Now, this is always interesting because there's so many different types of hair. Certainly, if we go globally, we look at, well, for example, some contrast. We look at Asian hair, which is usually thick, thickly rooted. The hair shaft itself is fairly straight, and that is a completely different than, for example, an African American who has a smaller hair shaft and a very curvy hair root that's pointing in different directions. Now, the difference very well may be how you have to care for that, where on one side that you may need, and you can use, for example, an African American hair such as mine, I can use oils. I could even use creams, although creams oftentimes will leave a white hue in my hair, so don't want to have that. I do wear mine fairly short, but oils are acceptable. Whereas many of my Caucasian patients, any oil treatment would weigh down their hair and have it laying flat, certainly not being cosmetically the best that they can get it. So different treatments have to be used. Also, the times in which you wash your hair are different. How many times do you need to shampoo? Where there's some hair that has lots of oil, again, weighing down that hair because it doesn't have the strength of the stock to push through that, and others are very strong and can do that. Hair care practices are different, and it's interesting that many of the products, the treatments that are there, don't recognize that. So the directions that have to be given to patients are different based on the type of hair they have, what their normal hair care routine is, the sensitivity that they may have to different products, because we also, while we're treating things, while we're trying to make things better, looks count. And being here in Beverly Hills, that's extremely important. I think it is anywhere you are, but here, especially if you're an on-screen personality, I can't give you something that you can't wear. I can't give you, if you're a school teacher, some harsh tar solution or cream that's going to smell up the whole classroom. Can't happen. Won't happen. Unacceptable. So being able to work with and find the things that work best with you, your type of hair, your habits in terms of shampooing become extremely important. The biologics. I am absolutely so happy that medicine came around, it was psoriasis' turn. Oh, yes, and it's got other things. It's got ankylosing spondylitis and rheumatoid arthritis and hidradenitis and Crohn's, and it's got other things there, but thank goodness with regards to biologics and psoriasis. What happened? Essentially, when we were using a shotgun to kill a fly, we were able to use a fly swat. Oh, yes, and I apologize. That's probably too simplistic for everybody that's on here, but the reality is that's it. Actually being able to focus in on the problem of especially inflammation, which 25 years ago, well, I'd make it 30 years ago, we weren't quite sure, and we were actually thinking that there was a problem with just the growth and the turnover of skin. But we understood what inflammation did. And again, just like different ways home, there are different pathways that these different biologics have that can get to a minimum that the FDA decided of a 75% clearance or better. So I also think if you take a look at what the safety and efficacy is with the biologics, I don't think that there's been another group of medications studied so intently that was put up with such a number of barriers that they needed to clear. Subsequently, it's gotten so good that they are having alternatives, what they call biosimilars along the way. But as with every medication, there's a difference, or there can be differences between the different ethnic groups in terms of the side effect profile, in terms of, in particular, not so much with the serious adverse events, but the things along the way. If there's something that may require a period of time that you go through where you may have flu-like symptoms, that may be longer in one versus another. Or if there's anything with regards to the having any stomach. And again, you know, I describe a lot of things to patients on a level where it's understanding for everyone. Most of these medications, you're going to get flu-like symptoms. You're going to have some congestion. You may have some upper respiratory issue or problem for a short period of time. The important thing is being able to stay in communication with regards to your dermatologist and your primary care. As I say, the other considerations with regards to the cost of the medications, most of the companies have programs that can help with regards to those who are below the poverty line, those who are above the poverty line, and those who actually are probably middle class or so. There are still opportunities to help pay against your copay, to get the medications for free. But part of all of that, you can thank the National Psoriasis Foundation for pounding the ground and volunteers from across the country making people know and understand and hear, shaking the trees that psoriasis is something more than just a rash. How you use these medications, other medications that you may be on because there are other problems. I think that all of you know that there are some issues with regards to what we call metabolic syndrome, which has to do at a higher, these patients, for example, psoriasis patients are at a higher risk for cardiovascular problems, obesity, diabetes, increase with regards to their lipids. All of these things are things that are associated with psoriasis that people don't know. Again, more than a skin disease. Talking to your doctor, finding support. We have walks. We have walks, folks, across the country, getting involved with regards to that, sending change, sending dollars, sending checks. All of these things help with regards to getting the word out. Again, I had the opportunity twice, actually, of being able to talk to Congress with regards to psoriasis. I've had multiple calls to my office since those talks, asking a question and getting them to understand more than a rash, more than a skin disease, being parts of clinical trials. Let me tell you, there are many people who believe that I'm not going to get involved in a clinical trial because I don't want to be a guinea pig. If you haven't been there during the clinical trial, once it gets released, you are definitely a guinea pig then. Understand, with regards to clinical trials, you're going to be watched closer than any other time after a medication has been approved. There are a number of barriers. There are a number of checkpoints that have to be done during clinical trials, so you're probably at your safest during a clinical trial when there's so much attention there. And those people of color, those folks of different ethnic groups are not being either informed, invited, or taking the opportunity to be involved in clinical trials. And I ask you to think again, if you have a friend or if you have it or your office is doing it, get your patients involved in that. There has not been enough. There has been far less. In fact, I don't know of any clinical trial dealing with psoriasis, and I do most of them, that has ever had greater than 10% of any other than Caucasian. And those numbers can get as much as 99% Caucasian on certain trials. So I'm really an advocate. I'm really pushing for whatever clinical trials are out there, consider. Yes, had an opportunity again to talk about the access to care, the issues and problems with regards to diagnosis, the affordability and the hurdles that are made, and some of them are make-believe hurdles. The insurance companies saying, no, you've got to go this way or this way, not the way that your doctor thinks that's going to be best for you, not the way that's going to specifically help you, but tell you that you've got to use medication A, B, and C before you can get the D, and that's what you should have had at first. So letting the officials know. But the most important thing for me with regards to Congress, again, is when they have hundreds of diseases that cross by their desk looking for some appropriation, looking for some monies, and we have to compete with regards to all of those. And I don't expect for psoriasis necessarily to say it's going to be higher than certain cancers that are there. But what I wanted Congress to do is to be able to take pause when they see the word psoriasis, not just go past it, but take pause and understand that we have 10 million people in this country that have psoriasis and that need their help. That's what was the important part for me in speaking to Congress on 2 occasions. So as I conclude this, I want to say that it's difficult to get a diagnosis. As they say, sometimes it's up to 6 or even 8 times. There are many folks that's the first time that I've seen them as a dermatologist. They've been to 4 other doctors on other things to try to get it right. More research is needed, and more, not only do we need to have the companies aggressively look for skin of color and including them in the studies, we've got to have people of color to volunteer to go out and be participants in the clinical trials. The signs, the symptoms, the look, remember my skin color and salmon color, you can't see that. If you had a test and you were looking at it, I would say, well, I'd be struggling with that. I'd say, no, I know that that's the one that I have to check, but that's just not what the reality is. The issue with regards to the cultural factors, how folks are treated by their local community, friends, even their family. Usually with regards to their inner family, that will be fine, but cousins or distant people who don't see and don't have the education, it can be very difficult to be ostracized. There are folks, there are different churches that don't want them to come in. I mentioned earlier with regards to gyms or participation, and just the burden, whether you're a bank manager or whatever you might do, your interaction and how people interact with you based on you having psoriasis can be such a problem. Get involved, be an advocate, educate someone. That's the best thing. And, you know, saying a kind word to patients who have that. I know somebody with it, so on and so forth. Hang in there. All of those things can be quite helpful. Here's some resources. I said if you go to the National Psoriasis Foundation website, there's nothing better in terms of being able to get information and to steer you in the direction and to be able to go in and ask your doctor questions, and if they can't answer it, find somebody else who can.
Terrific.
We're there.
Perfect. Thank you so much, Dr. Wallace. We're going to now dive into our Q&A portion of our webcast. So one of our first questions we have here, are there any medications that can brighten, darken skin color spots?
There's a variety of medications that can. There are a lot of different base ingredients that can. Obviously, everyone's heard with regards to using hydroquinone. Let me tell you one thing about it, though. The larger the number, it doesn't necessarily mean that it's going to be better. In fact, the larger the number, perhaps the side effect profile is a lot higher. I use between 2 and 6%. Sometimes that's compounded. But there are other medications that can be used to also lighten that are non-hydroquinone, because there are people who have sensitivities to hydroquinone, and also in other countries it can be illegal. So some of the other acids that are there. But remember, what you don't want to do is to, let me say it another way. There's a small window, and there's a window of when we stimulate things, and there's on one side. On the other side, it's when you irritate. In people of color, you cannot cross that line of irritation. Irritation brings on hyperpigmentation, and you can often be doing things that you think are good, but you're irritating, and you find that that actually gets darker. Another thing is, you can't fade, you can't get lighter on any sun-exposed area unless you're using a sunscreen. And a sunscreen is an SPF 30 or greater. Don't pay any extra money for the higher numbers. SPF 30 will block out about 94–95% of the harmful rays. But understand that it doesn't mean direct sunlight only. If you're sitting at an open window or you have your drapes or shades open, UV light bounces off of those, and it will also prevent you from being able to fade. Some of the over-the-counter products are okay, but usually yours that have pharmaceutical quality products are going to be the best.
Wonderful. Okay, we have another question here. What is the best way to manage psoriasis and metabolic syndrome in persons of Asian ancestry?
Well, I think that it's a behavioral thing that we need to take a look at. One, obesity, again, an inflammatory disease or problem has to be dealt with. I think that the overall health of patients, and that's where it comes in, that it's not just a skin problem, it's not a dermatology problem, it's a health problem. And I don't want to look at it as though that we can assume that medications are going to be the answer. I truly believe in the best of the East and the best of the West. I think that you have to come up with a meal plan that's going to work for you. I think that you're going to have to get an exercise program that's going to work for you. I mean, I see patients now, and I actually have been trying to do a clinical trial where they're doing the Fit Watches. And or if they're doing the iPhone, the Apple Watches of that, where people are watching their calories, where people are watching the number of steps that they've taken, and make this a goal to be healthy. I can almost guarantee you, if you can be more healthy, your psoriasis is going to respond to that. So I get to ask the question all the time about natural herbs and that. I'm all for it. But even with regards to the herbs, understand that you can do too much, which will have a negative side effect. Things in moderation are usually okay. Whether people are using things like coconut oil on their skin, shea butter on their skin, whether they're using turmeric, if patients are what else do I have patients use? I have them use some of the neem oils on their skin. Again, don't go overboard with any of the so-called Eastern medicines. The same way that I would tell you that you don't double up on any prescription you have because you say, well, if one is good, two is better. That's not the case.
Okay, wonderful. We have another question here. What are the best treatments for moderate to severe scalp psoriasis for people of color who tend to have dry hair?
I think that there's a couple of things. The number one thing that I want to say, do not get that comb out and try to scratch that scalp. What's going to happen there is that you're going to exfoliate some of the top layers of skin too much. You may get bleeding there or small cuts there. You can get a secondary infection. You can make yourself more prone to get a fungus in that area. What you have to do, and this is a difficult part, but do it just like for any of you who have ever fed a baby. If you're going to warm up something like any of the oils, again, I'd like neem oil. You can do any of the vegetable oils. If you're going to warm it up, make sure that you use your baby finger and put some on the inside of your forearm. Make sure that it's not too hot. I like for my patients to put some, pretty much saturate their scalp with it. I like for them to put a cap, and if you have opportunity to be able to go under a dryer, I think that that's good. You can use that oil treatment, one, to help to loosen the plaque that's there, and it should be able to come out with your fingertip. If it doesn't come out with your fingertip, wait for another week or so and do that. Also, with regards to using a very high keratin percentage conditioner, that's one of those. Again, it will help your scalp, it will help your hair, but it's going to take a little time. I don't think that you have to increase the amount of time that you shampoo, but you have to 100% condition your hair. And when you do the conditioning, your conditioning has to have some time to soak in to the stalk of the hair. So a minimum of 20 to 30 minutes it needs to be on.
Thank you. Most people have seasonal flare-ups. Why do some people, like myself, have problems all year long?
Different strokes for different folks. There's some people, the same reason that some people have their psoriasis on only one part of their body and not others. There's some people who have major flare-ups with changes of weather. There is, of course, some emotional, behavioral association that's that, and that's it. There's also some environmental that's there. One of the things that we're looking at in doing some of the epidemiological studies with, again, the Chinese that have it at such a high percentage in mainland China, are their kids or those folks who have immigrated to other countries, especially here in the United States, are they having it at the same level? So is it an environmental change that's there? Emotionally, there's differences, you know, especially during the holidays and Christmas time. That's a very, very stressful time for many people. Although there can be some joyous days, there can be a lot of depression. There's a lot of interaction that may happen. Again, coming in contact with people who don't understand your psoriasis. Major life events, divorce, losing a job, death in the family, all of these things can have an impact with regards to the severity of psoriasis that you may have. The great news is that we are so much further ahead now than we were at the turn of the century in terms of pathways for treatment that are showing a safer, more efficient benefits for patients who are being treated.
Wonderful. We have another one here. Can Retin-A be used to get rid of a scar from psoriasis?
Retin-A may help, but I would not say that is the claim to fame of Retin-A. And like so many other things, as I mentioned earlier, what works for one person may not work for another. In fact, what works on one part of one person's body may not work on another. I would say that wouldn't be my first choice. Understand this also. As difficult as it is, psoriasis usually will not cause a permanent scar unless you break the skin through your scratching or using instruments, back scratchers, brushes, loofahs, your fingernails. If you break the skin, there's a higher likelihood that there will be a scar. Certainly it'll make it more difficult, one, for Mother Nature to handle it, and two, for me to handle it as the doc that's trying to get you back to the best look that you can have. I tell most of my patients to maybe put a bottle of their lotion in the refrigerator. And if you have one of these attacks of the itching, use that cold because it will change the sensation that you have, and you may not do the self-harm to yourself that you would in any other circumstance.
Thank you. Another one here. One of our participants is curious on your position on the extract laser therapy.
I think it works great on some people. Again, different strokes for different folks. It works great in certain areas. Certainly if you have an isolated part or a plaque that just doesn't respond to others, it may be helpful. In my patients who had some mild and some moderate, it did. My patients who had severe, we clearly have to have them using some other modality, but we might be able to find a spot there. Let me just say this. One of the things that doesn't work well, and this is a little bit different, hypomelanosis, people of color, skin of color, oftentimes will have these sort of light spots, sometimes almost white spots, where it looks like the color has gone. The laser hasn't done well at having permanent results on that. Sometimes you can stimulate and get some color in it, but it seems to fade again. We need to do more on figuring out how to stimulate melanocytes so that they will continue to go. But it might be like hair. They may actually be just programmed to say that that's as much of the color that I'm going to make.
Thank you. Our next one here, there are not population stratifications regarding enrollment for skin color in clinical trials for psoriasis versus others. Do you feel this is necessary?
I think that whether you're old or young, male or female, thin or obese, all of those areas need to be looked at. I think that there are, and we've seen in so many other medications or treatments where there's a difference. There are some ethnicities that don't do well with beta blockers. There's some ethnicities that don't do well with a variety of other things. I want as many parameters that can be to be looked at so that we can at some point in time pull them all together and see if we can find some trends. I know that there's some differences in my patients, for example, my older patients versus my younger patients. I know that there's difference between some of my obese patients versus not. I know that there's differences both ethnically and culturally on the severity of this disease, and so I think it's so unfair to try to tell me that this patient only has mild disease when it's on their scalp, when it's just on their hands, and you're saying, you know, you don't have enough body surface area. What they have to go through and the burden with regard to this disease, and I'm not just talking about being inconvenienced. Again, I have the hairstylist who has fissuring in her hands because she has palmar plantar psoriasis. Don't tell me that that isn't a serious problem. And just as we do, and we look at hair, we look at some things that are only palmar plantar, we look at different types of psoriasis. I think that we need to be more inclusive in terms of diversity with clinical trials. And yes, I do think that we need to look at some ethnic profiles on our clinical trials.
Great. We have another viewer that's interested in what she can do for her psoriasis while she's pregnant or breastfeeding.
Well, my first thing would be the least amount would be the best. I have had patients who have gotten pregnant. I've had patients who were already pregnant. When I had them on some medications, perhaps a biologic. The good news is that I've got baby pictures in my office, and you'd think that I was a pediatrician of my pictures that I get every year of children who were born under that. I think that there's so many different environmental factors and genetic factors out there. If you can be off of your medications, you can. But in those choices, when patients have become pregnant or were pregnant, I have always asked them to go off of the medication, because I want to have, and not that I think the medications are necessarily bad for them or for the infant, including the time when they're breastfeeding. The issue or question is, for me, is I want to have their gynecologist, I want to have their significant other if they're involved, I want to have family members all knowing that there is some risk that's there. I want the patient to be the one to say, I want to take this risk. I'm willing to take this risk. Again, understanding the emotional burden of having this disease and how uncomfortable it could be to have that, and I won't even go to how uncomfortable it could be in the middle of the winter of the Northeast, or the middle of the summer of down south in Texas somewhere where it's 106 degrees there. The medications are not one to say, yes, you can, but they are very good. There's a scale of A to X, and most of the newer medication we're talking about are B's and C's, and those are showing very good promise. Again, all of my patients go off of medication, but there are some who end up going back on when we have a broad base of approval and understanding.
Great. Well, thank you so much, Dr. Wallace. This concludes our webcast presentation for this evening. But I do want to take a moment to thank our sponsors again. We want to thank Lilly for their sponsorship of today's educational webcast and making this event possible. And before we adjourn, I want to mention that a recording of tonight's webcast will be available shortly on our website, and you can access the complete archived websites by visiting psoriasis.org/webcast. Thank you so much.